Our next speaker is nationally renowned Georgios Pappas. Dr. Pappas is a physician from Greece, specializing in zoonotic infections and epidemic preparedness. He is known for his detailed report on the largest laboratory accident in Southeast Asia, which released brucella, and he recently published in the Bulletin of the Atomic Scientists a warning regarding animal hosts with COVID-19. Dr. Pappas will present on combating disinformation regarding COVID-19 and long COVID. Dr. Pappas, the floor is yours.
I'm honored to be here. Even with the most conservative calculations, today in Greece, someone will get infected, and this someone will develop long COVID and will develop debilitating, chronic, persisting long COVID. And most probably, they will be someone at a productive age. Long COVID is no more a medical emergency, a medical condition, it's a social condition. Just look at the numbers. This is from the US Census Bureau, recently published. 1.3 per 100 individuals is suffering from debilitating long COVID. The percentages are worse in the ages 40 years to 59 years, and particularly for females and also for transgender individuals. And if one wants to take decisions in terms of cost and health system burden, the effect is also major. This is a preprint from the United Kingdom detailing the cost of healthcare utilization by long COVID patients. More than £2,000 per person annually is the additional cost. This is an image from a 1944 film called Gaslight. The great Ingrid Bergman got her first Academy Award for it, playing a young woman recently married. She was full of life, she was full of hope and interests for music, etc. But her husband was gaslighting her. He was trying to drive her mad by organizing strange sounds from upstairs and the lights going on and out. And he was trying to persuade her that it was all in her mind. He was trying to persuade her that the reality is different from what she was perceiving. This was where the term of gaslighting was drawn from, and now it has entered most medical dictionaries, most respected dictionaries, and now we have also the medical gaslighting. Medical gaslighting has been the focus of much interest, and traditionally, medical gaslighting targets women. A very instructive example of this is multiple sclerosis. MS, until the mid of the 20th century, was considered a predominantly male disease. Why? Because female symptomatology was easily attributed to their minds. It's in your mind. You don't have anything. You don't have a neurological problem. You have a psychological hysteria, for example, or anything like this. I think it's a feeling that it's a situation that may sound familiar to many long COVID patients, female patients in particular. Long COVID patients suffer from epistemic injustice. This term that was coined by Miranda Fricker encompasses two aspects. There's testimonial injustice, which means that long COVID patients express their feelings, describe their symptoms, but they are not taken seriously because they are not considered experts. They are patients, they are not medical experts, so everything that they say cannot be accredited. And there's the hermeneutical injustice also. The problem with long COVID is that it's a too broad phenomenon, a too broad condition with many different presentations, and there's no specific framework that we know of. It cannot be readily explained by past knowledge. So it's more easy for some people for some practitioners to discard it as non-existent. So we need to find a pathway to go from epistemic injustice to epistemic solidarity, the one that Miriam Pott has recently described in a very interesting essay. We have to remember, regarding long COVID, that the symptoms may be significantly different from one patient to another. And we also have to remember that there is no paraclinical endpoint. There's no diagnostic test that will help one to say definitely that one has long COVID. And we also have to remember that long COVID is most common in females, the typical victims of medical gaslighting. This is from the Greek collaborative study, previously also shown by Dr. Ioannidou. My interest here is that many patients visited too few doctors. Perhaps these patients were not even aware of the entity of long COVID. They didn't even persuade themselves that they suffered from long COVID, and they felt that everything was psychological, and they didn't pursue a medical examination, a medical evaluation. And there's the other end, the patients that were examined by more than 10 doctors, either specialists or physicians or general practitioners, and these people didn't find any worthy response in their quest for evaluation, for understanding, for diagnosis. Now, unfortunately, there is a lot of literature, scientific literature on the prevalence of medical gaslighting for long COVID patients. I will go briefly through some of these presentations. These detail patient experience, and this particular study notes that the patients are not only disappointed by the ignorance and gaslighting, but they are disappointed by the absence of epistemic humility. The failure of the medical practitioner to accept that the medical community doesn't know much about long COVID, the failure of continuing medical education, the failure to work with the patient to understand their symptoms and trying to find therapeutical solutions. And this absence of humility is even more shocking when the patients themselves are healthcare professionals. There is a major issue with that in the United Kingdom, and the very active community of long COVID patients who are healthcare practitioners, but they feel that they are gaslighted by their own colleagues. Doctors need to remember that long COVID patients may suffer from brain fog. Brain fog is a major issue. The patients may not be able to articulate their experiences and situations. These experiences should not be discarded easily. And of course, finding the right personal doctor, the right general practitioner is an experience which may not be therapeutic, but at least may be supportive. A proper doctor will not refuse diagnostic testing, for example. The doctor should acknowledge the fact that these tests may be inconclusive. The doctor should bear in mind that the differential diagnosis may include other conditions that may be similar to long COVID, or other underlying conditions that were until then undiagnosed, but should not defer testing. Deferral of testing is gaslighting. And of course, when healthcare doesn't recognize your situation, as a real social environment develops, your family may not believe you. Your husband or your wife may, or your father or your kids may tell you that you're okay. The doctor said that you have nothing. It's all in your mind. Your employer also may tell you that you have nothing. And this is a major issue, the occupational problems of long COVID patients and their occupational future, which is endangered or lost in many of the cases. The whole life of long COVID patients with persistent diseases is obviously destabilized. And of course, we doctors can be very persuasive sometimes. Thus, a significant percentage of long COVID patients end up treated with benzodiazepines or are being diagnosed with pandemic anxiety. Pandemic anxiety, it's what a term that we keep using, even though we are pretending that the pandemic is over. Now, gaslighting is only a part of the whole misinformation, disinformation, malinformation landscape. Disinforming on long COVID is of benefit to many. Its denial or its minimizing augments our sense of return to normal. We went back to the pre-pandemic times, we think. It allows us to act as if there's no virus around us, or as if it's another flu. And Professor Birks already explained why coronavirus is not another flu. It allows us to consider endemicity as an acceptable burden, but we haven't talked about how we decided the number of deaths that is an acceptable burden and the number of long COVID patients and debilitation that is acceptable. It discards the need to take complex decisions, to spend on prevention, on research, and the need to reinforce certain mitigation measures as the use of masks. But ignoring long COVID and disinforming on this is thus convenient for the state because it doesn't have to pay anything to take difficult decisions, to make strong mitigation measures. It's useful for the society. Remember how easily we as humans can slide to developing a racism of the healthy. And we keep forgetting that we may be one infection away from long COVID development ourselves. It's convenient for the media also, because the media don't want to report on something so complex and depressive. It's convenient sometimes even for healthcare personnel who don't need to study so much, and long COVID is an evolving condition, and the long COVID research is daily updated. And of course, someone else who benefits from this information on long COVID, and it's the usual suspects. Who are the usual suspects? The merchants of hope. The ones that disinform in order to profit, the ones that take advantage of the therapeutic vacuum and promise miracles. You know, when a long COVID patient is so desperate, you promise them a miracle, then you take advantage of the fact that belief is a beauty thing. This is a lyric from a Simple Minds song for those who like this group. And gaslighting patients with long COVID opens the door for these merchants of hope. This has been demonstrated that gaslighting the patients, rejecting the patients and the truth of their symptoms, leads them to rejection of classic medicine, and then their orientation towards alternative or complementary approaches that are often not moderated. And we know that this has happened. We have seen it published and reported. We have seen the BMJ investigation about the numerous European clinics that offer apheresis and intravenous vitamin infusions in long COVID patients, costing tens of thousands of euros, all this. And we have a recent publication about the supposed stem cell therapies in clinics, in 60 clinics in the US and Mexico. There's a lot of false promise going around and minimal moderation at the moment. Nobody is searching how these clinics everywhere in Europe and in the United States and Mexico are still functioning and are still promising futile future for these patients. And we have also seen disputed treatments for neighboring conditions gaining traction again. Sometimes this is essentially a malinformation because it harms the patients. For example, the question about graded exercise therapy. When the first long COVID patients emerged, graded exercise therapy was considered by some very promising approach for rehabilitation, because there was this study done on chronic fatigue syndrome by Michael Sharp. And then we do know that this study has been disputed about the soundness of its evidence, but still it circulated, and some people still continue to advocate graded exercise when it's not that beneficial, on the contrary. If we have to find a way out of disinformation and gaslighting in long COVID, we have to focus on the example of HIV, for example. It's through patient advocacy that we may reverse it. Remember that the patient-led research collaboration, the patient initiative, went on to be used as a data source for the CDC through Ed Yong's journalism. And we need more journalists like Ed Yong. And then we ended up in reviews in major journals, co-written by leading scientists like Eric Topol and leading activists like Hannah Davis, the review already shown by Professor Birks. It's the citizen scientists, as Francis Collins called them, that should be encouraged to start a battle against disinformation on long COVID. And it's the duty of us physicians and of public health officials and everybody else of the public to stand by them in order to fight disinformation. Because we have to find a way out of disinformation in general. So the second part will focus on disinformation on COVID in general. You have heard about the infodemic. It's more dangerous and deadly than any SARS-2 variant. And we all understand that erroneous information may sometimes be dispersed due to misconceptions, due to illiteracy, due to our limited understanding. But we have to look at what's at stake. Anytime a significant piece of information circulates, somebody has a backstory on it. This is particularly important because we are living in the era of post-truth, in an era where we consider true what mostly affects our senses, in an era where our attention deficit allows us to forget history and facts, For example, we have been living the pandemic revisionism, where many people are trying to persuade us that the initial lockdowns that saved lives and gave us some important time to understand the virus and develop some weapons against it were harmful. We are supposedly reaching the genomic area, the genomic unknown, something like the film Gattaca, from which the picture is here. But instead, we are characterized by all these things that Czeslaw Milosz described in his Nobel acceptance speech back in 1980. The truth is too complicated to handle, and thus we choose to forget it sometimes. Of course, our post-truth era is characterized by accepting as true the louder opinion, or the most multiplied opinion, or the opinion seen everywhere. But sometimes this everywhere is originating from false identities and bots, as we will say immediately after. And even more unfortunately, even worse, we are in an era that considers what is voiced by popular icons as true. We are rapidly derailing from the era of evidence and science-based medicine to the era of media-based medicine, and even worse, celebrity-based medicine. Remember that early on, a famous actress, Gwyneth Paltrow, proclaimed that she knows an alternative cure for long COVID. Gwyneth Paltrow may be an Academy Award-winning actress, but still she's an actress with dubious opinions on personal health and hygiene and public health. And the NHS head was still compelled to publicly refute Gwyneth's claim because they were that influential. Because many people turned to Gwyneth Paltrow for advice on long COVID instead of science. So, who disinforms? The answer is simple: who profits? And there are two basic pillars of disinformation. First, individuals with long-standing anti-vaccine stance. The disinformation dozen, as described by the Center for Countering Digital Health. These people have also been proven that they profit a lot from pushing for their own stories, for rejecting vaccination, for spreading lies, and pushing their own products instead of vaccines. And the second main pillar is certain states, with China and Russia being the major ones. Russia, in general, disinforms, and has been doing it for long, in an effort to weaken Western democracies, while China is a newer player and disinforms in order to strengthen its own position against the West. So they use a different agenda and different way of disinforming. Now, when you have been a professional in disinformation, it's easy to develop a complex network. You may have heard of Operation Infection. Back in the 80s, the Soviet secret agency attempted to spread the rumor that HIV was deliberately made by the US. It's a well-documented history nowadays with a lot of evidence. But Russia knows how to spread disinformative rumors. It uses the fire hose technique. It spreads too many rumors altogether and then sees them multiplying. And in the process, Russia recognizes novel channels that can be of help in further spreading disinformation. It has been extensively analyzed in terms of anti-vaccine disinformation, both prior to the pandemic and through the pandemic, both by the US and by European Union authorities. And of course, disinformation may be profitable too, not only for the ones who are spreading the maligned information, but also for the platforms that are being used. Because you create a rumor, then you multiply it by bots, fake identities, you create noise, and then this noise gains traction and is being adopted by real identities. And this further multiplication of the noise means advertisement means money. One of the strangest things regarding this information that you have observed during the pandemic is how the far right of QAnon met the far left countercultural representatives, the wellness community. They merged in a joint disinformation campaign. The hippies and the yappies, as was the tagline in a long forgotten 1990 film called Flashback. I wouldn't recommend it. But the ones that want to spread disinformation have an eye for recognizing where there's fertile ground for disinformation, for spreading it. They target individuals at loss that need simple answers to complex issues. And simple answers can be passed off as stigmatized knowledge, the knowledge that they don't want you to hear. Who is they? An elite. They target people that are disappointed by social inadequacies. They are people that are illiterate in all aspects of literacy, either science literacy, med literacy, e-literacy, or media literacy. They target people in need of belonging. They offer them a team. They offer them colleagues. They offer them a sense of a common aim. And of course, they offer them a mission. Of course, this is not a mission from God as the mission of the Blues Brothers. And another issue, the disinformants, the spreaders of disinformation have taken advantage of is the World Wide Web and the social media. They have used it more extensively than science and public health representatives, and everybody now can proclaim that they are doing their own research. And their research is considered by them equal to decades of study in personal and social scientific evolution. This is from a study from Stephanie Alice Baker, who enlightened us a few days ago through Health Watch USA on the distribution of information through the pandemic. 28% of the participants in the study stated that they took their own independent online research about COVID-19. They are the ones who feel adequate, who feel well-equipped to do research. Finally, what do we do about misinformation and disinformation? As an excellent recent review underlined, one approach is never enough. Disinformation has to be attacked in all levels. The problem is that individual approaches have drawbacks. If you debunk or pre-bank a false information that's been doing circles, then sometimes you may offer it credibility. If somebody has not heard about it, then he may question themselves and they say, why this is debunked or pre-banked? Why the official state or the official science is against it? I haven't heard of it, but now I'm hearing of it. I'm listening to it. I'm reading it. I'm getting to know it, and perhaps I will be persuaded. And we have to remember that it's well known for ages. Jonathan Swift said it, that falsehood flies and truth crawls. One could say that we should moderate content, but it has not been very successful during the pandemic. There were attempts, but attempts were so-and-so. For example, a video was prohibited, but snippets of the video were allowed. So one platform moderated at a certain level, the other platform forgot to moderate. And of course, you can't control all platforms. A new platform will emerge, and then all the conspiracy will go there. People like conspiracies because it's, as we said, it's a simple answer to a complex situation. Of course, we should use the law against disinformation spreaders. It hasn't happened a lot. I don't know if there are many legal labyrinths about it, or one is afraid that can be accused of ending democracy, but we should see more legal action against these disinformation spreaders. It's a constant concern here in Greece, at least. And of course, we have to educate. This is a long-term solution, but it's a necessary solution because disinformation is here to stay. And the vaccine crusades are here to grow. Who will educate? We need community leaders because some communities have this belief against the state. For example, the Afro-American community have this belief against scientists due to the Tuskegee study in the past in the United States. But we need community leaders to serve as an examples and to infiltrate the communities. We need to use the vaccination contagion notion. This means that I can be an example for my neighbors, and I can be an example for my friends, for my social circle. And of course, we need the first-line healthcare workers who remained one of the most trusted authorities. And of course, we need to use the media, but we have to educate the media because the scientific literacy of the media is sadly missing nowadays. We need to understand what the battlefield is, where the battlefield is. We have been focusing a lot on social media, for example, but a vast disinformation circle evolves in real life. We still predominantly live in the real world and not in the digital one. And disinformation spreads in neighborhoods, in cafes for the elderly, in churchyards, everywhere. Of course, we have to go back to school to educate children how to handle information, tools developed for this. But we have to rush. As Sander van der Linden said, the democratization of propaganda creation through artificial intelligence is one step away, one click away. And the future world, the future generations are digital ones. not real life ones. So we have to be ready. But will we be able to define truth? This is a scene from an excellent UK series called The Capture on deepfakes, on how truth cannot be easily understood and can be easily defined in our times. Fake is getting too persuasive. Until then, we have, at least for now, to differentiate truth from our point of view. We still can. It will at least help our fellow citizens with long COVID and perhaps the future generations. Thank you.